Wrapping up our first annual Strength and Conditioning Coaches Clinic will be Dr. Brittany Rassel. She's a physical therapist at the Mess down the road here in Lake Wales, and she's going to be talking about Prehab pros. So I'll let you give a little more introduction.
Thanks, Stephen.
You're welcome.
So I did my undergrad in human performance, advanced work, exercise science, and then continued on for my doctorate of physical therapy. So I've always been in practice for over 6 months and graduated a year ago. So I'm going to kind of turn the tables a little bit. You guys have been all macho and testosterone. There's too much going on. So you're all about getting stronger and lifting weights. So today I'm going to talk about if you spend so much time in the weight room and want to perform well on the field or on sport, you also have to be strong in, I guess, smaller areas of your body. So specifically your shoulder and your lower extremity, or your shoulder and your hips. So the shoulder for the upper extremity and your hips for your lower extremity. So prehab curls is my topic. Curls being just wisdom to take back into the weight room. Alright, so an overview of what I'm going to do. I'm just going to give my approach for injury prevention of the upper and lower extremity. So we're going to talk about building the foundation, and then key areas for shoulder pathology, key areas for hip, knee, ankle, and foot pathology, and then exercise examples for both the lower and upper extremity, and just kind of some anecdotal case studies that I've done in the physical that I've been practicing with the geriatric population, but also some student athletes. So the key thing to first talk about is proximal stability allows distal mobility. So you have to be strong in your proximal areas of your body to allow for mobility in those distal areas. So proximally, meaning your shoulder for the upper extremity, allows everything else to function, your elbow, your hand, so any type of coordination. So we're talking about upper extremity athletes such as volleyball players or baseball players. You need to be stronger here to allow that coordinated movement of your elbow and hand to strike the ball and throw the ball. For the lower extremity, you have to have significant strength and stabilization in your hips to allow your knee, ankle, and foot to accommodate to the various surfaces or agility movements that you may be doing in your sport. So strengthening the muscles that surround the shoulder and hip joints will decrease the potential for additional stresses that are placed on the distal joints of the upper and lower extremity. So current treatment in the area of physical therapy, but also just general injury prevention, is geared towards strengthening the hips and the shoulders to decrease injuries throughout the rest of the body. So the injuries that I'm focusing on are more of your overuse, repetitive injuries, not necessarily something that, you contact in the sport where you can't do a whole lot about. You can help it a little bit, but if they're going to collide or there's significant amount of stress on an athlete and they're predisposed to an injury, there's not a whole lot you can kind of prevent in terms of strengthening. So we're going to talk about the upper extremity first, and we'll talk about the shoulder. So the rotator cuff is the primary muscular area that provides the dynamic stability for your shoulder. And the key word is dynamic. So if you think about most of your athletes that you're going to be training are not static. Okay, you're all moving, you're doing whatever sport-specific activity for that athlete. So the rotator cuff is a key muscle group for your dynamic stability, specifically more overhead athletes. And it works to offset the strong pull of the deltoid muscle, which I'll talk about on the next slide. It's made up of 4 muscles that surround the humeral head. Humeral head being the arm bone on the top, or the ball on the top of your arm bone and the shoulder bone. So you have the subscapularis, which does internal rotation, which is going in towards your body. You have your supraspinatus, which does abduction, or lifting away from your body. And then infraspinatus and teres minor do rotation away from. Okay? So those are the main functions of your rotator cuff. All 4 working together to provide that dynamic stability for the shoulder. The specific and key one is the supraspinatus, and the one that's usually is targeted for that overuse repetitive injury that may occur with some athletes. So when an athlete or a person in general has a rotator cuff deficiency, that means that the rotator cuff, all four muscles, are not working properly to offset that strong deltoid pull force that it has on your arm or your shoulder joint. So these are some fancy little force vector diagrams to kind of give you a visual of how your shoulder works and the various muscle pull that it has on it. So let's start with this one here on the left side. This is your deltoid right here. The main function of your deltoid is to provide a superior or upwards pull on your arm bone. Then we have the second one is where your rotator cuff muscles come in. Okay, they're providing more of an inferior and inward pull to offset your deltoid. So this is kind of a net force that you can see. If you have the deltoid going up and the rotator cuff going in, you have this net force to keep that humeral head right in the shoulder joint where it should be. So let's talk about how our shoulder moves when we move our arm. So if you're going to raise your arm up like this is your shoulder blade, and this is your arm bone. Okay, this is your joint that you have. So as you move your arm up, the humeral head of your arm bone rolls up, and then it's supposed to glide down. So it rolls up and glides down. If your shoulder and your muscles work properly. When you have a rotator cuff deficiency, you only have that upward pull of your deltoid, and there's no downward rolling because your rotator cuff is not providing that counter force. Okay? So that predisposes athletes or individuals for shoulder impingement, and then various other shoulder pathologies that can further continue. Labral tears, bicep tendinopathies, all sorts of things. So if we don't have an intact and efficient rotator cuff working, then you're going to predispose yourself to more shoulder growth. Now when you start adding weight and excessive lifts, and you don't have enough stability in your shoulder joint, then you're going to increase your risk of that injury. Okay? So on top of your rotator cuff dynamic stability, you also need scapular stability. So when you look at an athlete or you're trying to prevent an injury for any particular person, you want to look to make sure that their rotator cuff is strong and efficient and that their scapula is stabilized. Okay? So your scapular stability comes with the glenohumeral joint, which is the joint we just talked about, your arm bone and your shoulder blade working together. But we also have this, most people call it a false joint because it's not an actual ball and socket or true joint that the rest of our body has. It's your scapula on top of your rib cage. So you can see the picture here, your scapula and your rib cage. That is what forms your scapulothoracic joint, which also helps your shoulder move. So the key to increase your scapular stability is your upper trap, your lower trap, and your serratus anterior all working together to make sure that that scapula does not lift off your rib cage when you're moving your arm. So if you've heard of scapular winging or long thoracic nerve palsy, is when if you look at a person's shoulder blade and you see that lower angle pop off. They don't have enough muscle function to keep that shoulder blade attached to the rib cage how it should. So the main function of your serratus anterior, which is the key muscle that I like to target for most individuals, is what connects your scapula to the rib cage, and it helps to secure that shoulder blade as you're moving your arm. So we'll get into common shoulder injuries. Impingement, like I talked about. Does everyone know what impingement means? Everyone kind of throws that term around, but it's kind of a global term or a gross term that some people don't really know what it means. So here's a picture of it I threw up there. Impingement meaning that strong pull of the deltoid muscle, bringing that arm bone up when we reach overhead, and you get that end range pain that's right on the top of your shoulder. What's happening is you're pinching bursa, which is a fluid-filled sac. You're pinching all of your rotator cuff muscles that go under that area. It's right under your acromion, which is that tough bone right here on the top of your shoulder blade. So what's happening is there's supposed to be a nice open space between that area where everything kind of runs through. But unfortunately, when our rotator cuff, like we talked about before, doesn't work to give that downward pull on your humeral head, everything starts pitching. So So an impingement can lead to rotator cuff tendinitis or tendinosis. Tendinitis meaning acute injury, inflammation, maybe 1 to 2 weeks. Anything after that is considered a tendinosis, meaning that tissue hasn't properly healed. People went back to their regular activity that caused the pain in the first place after they started feeling good a few days later, and it's re-aggravated, so it's a vicious cycle, and it's caused into a tendinosis. Rotator cuff tears, so when you get a partial or full thickness tear of the rotator cuff, that repetitive activity just keeps slamming, and the tendon can't withhold stress. Labral tears. Labrum is a deep socket shock absorber in your shoulder. So what happens is when there's significant repetitive stress, or if you have a strong pull on your bicep, it can actually tear the biceps tendon off, and it's attached to your labrum, so that can come off. Bicep tendinopathy, whether it's a tendinitis or a tear. And then we talked on a little bit the multidirectional instability. So when you don't have a whole lot of stability throughout your whole shoulder joint, whether it's the anterior, posterior, your scapula, your rotator cuff, and that's what scares me about snatches and the Olympic lifts, is if you don't have this proximal stability in your shoulder joint, and you're loading yourself like Ben talked about, and you're not doing the proper progression and approach, you're going to set yourself up for injury. And then we'll talk about upper cross syndrome. So Narciso talked a little bit about this, about posture, and really working that posterior chain. So poor posture is going to predispose weak and overactive muscles. So the diagram here it shows a forward head posture, rounded shoulders, you got that thoracic kyphosis, and then you may have a little anterior tilt of your pelvis, depending on the tightness down there that we'll talk about later. So what you have is you have overactive upper trap and levator scapula, so that's where we carry a lot of our stress. So people will start to have shoulder and neck issues up there. We got weakness in our scapular stabilizers that we talked about, so that brings the shoulder blades back and down to give you a nice upright posture. And then guys are famous for this. All they want to do is bench press. Not specifically you as strength and conditioning coaches, but an athlete who's not well educated, all they want to do is bicep curls and bench presses just to get that muscle tone. So that predisposes them to that rounded shoulder posture. You get internal rotation of your arms, and you can see that opens up your back area. You have no strength in your posterior chain. So with that rounded shoulder posture, that's going to predispose you to more shoulder injuries. If you're trying to do some overhead activities, or if you're an overhead athlete and you're already in that rounded forward shoulder posture, it's going to cause more impingement and then lead to further injuries. So you guys are definitely on the right track of strengthening your posterior chain to get all of that upper pulling motion strength to help your posture, push your shoulders back into a good position that they can function properly. Anybody have any questions so far? Am I going too fast? No? Okay. All right, so I want to talk just about, these will probably be simple exercises compared to what you talked about today, but I think they're very important. So I'll give you some exercises that I use to target your rotator cuff, but also your scapular stabilizer. So the first one is full cam position. A lot of people would do empty cam, but I found that if they're already predisposed for impingement or rotator cuff injuries, there's no sense on just cranking out empty can exercises with your thumbs down and having dumbbells in your hands, because now you're just pinching that rotator cuff every time you bring this up. So I prefer to have a full cam position. Anytime your thumbs are up, that's going to rotate your arms out and free up that space that we talked about that runs under your acromion on that top part where impingement is susceptible to happen. So full cam position, thumbs are always up. You want to come out at a 45-degree angle. Now, with these exercises, I don't recommend heavy loads to start off with. You want to make sure that you're activating your rotator cuff tendon and first activating, facilitating the muscle, and then you can add weight. So let's not start with 20 pounds of full cam exercises, because your deltoid is going to start compensating for the weakness in your rotator cuff. And then we'll go back to where we first started. That deltoid is stronger than your rotator cuff, so now you're getting that superior translation, impingement, and the rotator cuff really isn't getting any work. Then we'll move on to side lying or standing external rotation. So side lying here, I like to kind of start off as your initial progression with hyperspinatus and carries minor strengthening. Then you can progress to standing external rotation with some bands or your cable machine. Again, starting off with a light load to make sure you're actually facilitating your rotator cuff and not overactivating your deltoid muscle. The next ones are primarily for your upper back strength and your scapular stabilization. So I like to start off with scapular punches and number drawing. And Kevin Wilkes is a big wig in the physical therapy research that has actually done a lot of research in these two particular exercises, scapular punches being this particular photo right here, and then same position for number drawing. So let's demonstrate that. If you are starting with scapular punches, you're laying here, you can have a dumbbell, but first start off just activating. The cue is to use your armpit muscles. So I want you to keep your elbows straight. You're going to lift that shoulder blade up off the floor, and then back down. So you're primarily facilitating that serratus anterior, which helps keep that shoulder blade on the rib cage. Okay? Then you can start in that same position and do number drawing. Number drawing means that you're going to draw the numbers 1 to 10 on the ceiling, or you can do letters. Same thing, start off without weight, then you can add dumbbells, using the same muscles to facilitate that serratus anterior. So it's big shoulder movements, but you're controlling it with those armpit muscles. Has anyone seen those before or incorporated them? Yeah? And then the other one would be a good progression for higher level athletes once they get the proper muscle facilitation would be a push-up plus. So getting in that push-up position and then adding that punch, that extra movement where you're facilitating your serratus anterior. Okay. All right, then we get into rows of shoulder extension. So you want to facilitate the upper back, get the scapula in retraction. So any type of rhomboid exercise, latissimus dorsi exercise. I really like shoulder extension to facilitate the lats and standing. And then Joey showed this in his video with the Y's, C's, W's, I's, but really starting off with light weight so you can really activate those key muscles before you start adding things. Any questions with any of those exercises? Let's move to the lower extremity. The hip is the similar function for the lower extremity like the shoulder is for the upper extremity. So we'll talk about your gluteal muscles being the rotator cuff of your hip or lower extremity. So as we wanted dynamic stability in our rotator cuff, we want dynamic stability in our gluteal muscles for our lower extremity. So there's 3 that comprise the gluteal muscle complex. Maximum being the big one in the back side. Medius is probably the key, like the supraspinatus is for the upper extremity, and then minimus plays kind of the minimal role for the lower extremity. So stabilization of the lower extremity, key things or movement patterns that you want to focus on, is hip extension, external rotation, and abduction. It's shown positive results for the necessary stability that you need for the rest of your distal extremity. So some key things that you want to assess, so when athletes come in, like you guys did in the fall, of a functional movement screen, just doing their single leg stance. So if someone is significantly weak in their hip abductors, you're going to see this lower diagram, you're going to see this pelvic sinking or dropping. Okay? What happens is your glute medius, which is the key muscle, facilitates hip abduction. So this movement here. What happens is when you're standing on one leg, you have to facilitate both hip abductors. So if you're standing on your left leg and your hip sinks to the right, which side is weak? So in this picture here, if I'm standing on my left leg and my hip dips to the right, which side is my weak side?
Left.
Yes. So the function of your glute medius is to bring that pelvis back down towards the side of your hip. Okay? So it's pulling it down. And that's kind of confusing. You would think that okay, my right side's tipping down, so I guess my right side may be weak, but actually it's this side because it's not strong enough to offset the weight of my pelvis. And then obviously looking at both sides. So this one here, probably be more specific for your athlete, would be just a step down test. So if they're on a step and I'm stepping down, key weakness indicator is going to be that knee valgus position where your knee goes in, your knock knee position. So you want to assess. They can be on a small step if you don't really see anything, progressing to a bigger step, and see if they contract that knee laterally. It should be midline to a slight laterally. It shouldn't be in like that. Okay, so those are some quick assessments that you can do to see if they have any hip abduction weakness. You can also lie them down and have them hold it up and press down on them like a manual muscle test. But those are some functional activities because they're actually in a weight-bearing position. They're on single leg, so it's more of a functional, sport-specific assessment. All right, so weakness in the hips can cause IT band syndrome, patellofemoral pain syndrome, trochanteric bursitis, plantar fasciitis. So IT band syndrome, tightness in your IT band. Most of us, probably all of us, are very tight in this muscle. Actually, it's not a muscle, it's connective tissue. So what happens is the IT band has to compensate for the weakness in our hips to give us stability in our knees. So a lot of people, if they have pain along the lateral knee, lateral thigh, or even if their hip area, you want to see, yeah, their IT band may be tight, but that's a symptom. So why are they tight? Is it because they have weak hips? So you want to assess the weakness in their hips. Research has shown that if you increase hip stability or abduction strength, that the IT band will be as overactive or tight, and you can decrease that pain that they have. Patellofemoral pain syndrome is a fancy term for anterior knee pain. More specifically in women because of the larger Q angle that we have for later on in childbirth years. So the wider hips in a female causes increased stress in your knee. So you see that with the wider hips, you're going to need more stability to decrease the stress that goes through your knee, and then subsequently in your ankle and your foot. So with female athletes, and male athletes can have this too, but if they come in with anterior knee pain, you want to check their IP band because that's probably tight, but also the weakness in their hips. Also looking at the quads too, but if you correct the weakness in their hips, everything else kind of follows. Trochanteric bursitis, meaning just hip pain. Again, if IP bands are tight, it's constantly rubbing over that trochanter or greater trochanter. So again, strengthen your hips to decrease the stress on the IP band, that then takes away from your hip pain. And then plantar fasciitis. You wouldn't think that pain in your bottom of your foot would actually be correlated to the lack of strength that you have in your hips, but it can. Because as you see, everything in your lower extremity is connected, even your low back. Interdependence, I forget what that's called. But again, everything is connected. So if an athlete comes in, they're complaining of plantar fasciitis, they've been dealing with this forever, you want to take a functional look at their hips, their quad strength, their IT band. You want to take a gross look at them because probably the ETs are only treating their symptoms to get their pain down and get them back on the field. So it's your job as a strength and conditioning coach, if the physical therapist isn't on staff, to actually assess their weaknesses and get them back to where they're preventing injuries all over, just not the one that they have right now.
On that slide,
Yeah.
Go back to that slide. On that patellofemoral pain with the anterior pain, like what would be like your top 3 treatments? You're talking about IT band.
Yeah, IT band, hip work, and then TKEs for your VMO or quad. You want to see if the patella is it lack of tracking, and it may be lack of tracking because of weakness in the VMO, tightness in the lateral side of your IT band. So it kind of all correlates, but those would be my top 3, is looking at flexibility of their IT band and also hip flexors, strengthen their hips, extensors and abductors, and then strengthen their quads, specifically VMO, but also their hamstrings too. So it's kind of a gross picture that I would look at. Just to explain these two, you can see the correlation between the IT band and your glutes, that your IT band actually connects to your glute knee. So like I talked about, contraction or the stress on it is greater to support the distal knee joint down there. And then with knee, when I talked about weakness in your hips and you see someone and their knee comes in like that, that's that knee inward movement, then it creates just a downward fall throughout the other joints. Your leg internally rotates, your foot over pronates. So repetitive constant activity of an athlete who has that weakness and causes everything down the chain can then predispose them to other injuries. Overpronation of foot being plantar fasciitis. Inward movement of that knee, MCL sprains, or eventually tears. Internal rotation that can cause ankle issues, some pain there, or even your knee pain because that tibia is just rotating. And then like the upper extremity where we had your upper cross syndrome, there's also for the lower extremity a lower cross syndrome. So you guys really pointed out a lot of importance on muscle imbalances. Not necessarily front to back like these cross syndromes are, but also weakness in the little muscles compared to your bigger gross muscles. So with lower cross syndrome, any muscle imbalances, whether it's tightness or weakness, causes abnormal pulling forces on body structures. So in the lower area, you have weakness of your hips, tightness in your hip flexors, which gives you that anterior tilted pelvis. You have weakness in your thoracolumbar extensor, so you don't get that upright posture, and then weakness in the glutes. So exercises, these may, again, be a little juvenile for your setting, but I think they're important to actually get the muscle facilitation. So side lying and standing hip abduction. I really like to start off in side lying to make sure you're actually activating your glute med, because it's real easy. Our body likes to compensate with the least amount of stress or energy expenditure possible. So your body is going to find the strongest muscles you have to do that movement. So if you're not feeling this in the side of your hips, you're not doing it correctly. So the middle picture is what I like to start off with, clamshells. So just opening up into external rotation. So you're getting a little piriformis, but you're also getting your glute med activation. Then going into straight leg side lying abduction, really making sure that you're feeling it on the side of your hip. You're going against gravity, you can then add some ankle weight. And then getting into your functional weight-bearing standing position where you can use a cable, but even just single leg proprioceptive balance to try and facilitate the strength in your right hip abductor too while you're doing that. And then to get some hip extensor, double leg bridge, then progress into single leg bridge on a physio ball. You guys all know there's different progressions, but those are what I like to start with just to make sure you're activating specific muscles. So we can talk about clamshells, hip bridge, band walks are good. I like those. I like to internally rotate the legs, so you're making sure that you're facilitating glute med, but you're also getting glute minimus by doing that internal rotation. When you start going into external rotation, you're facilitating more of your stronger hip flexors and your quad, your rectus femoris, and then you're getting your stronger hip extensors by doing external rotation too. And then Steven is famous for developing this quadruped hip series, which is really good. So I like starting off with body weight and going to resistance bands, ankle weights, and then cable machine. Again, making sure you're doing the progression so you're targeting the muscles that you're trying to strengthen. So the last part is just some anecdotal case studies that I've seen in the short time that I've been a physical therapist. And it's actually kind of cool to see a person come in with the first one being a rotator cuff that was inoperable. So they couldn't attach it because of just the thinning of the rotator cuff. So this guy was actually a water skier. He was a bowler and a golfer. He came in, couldn't even raise his arm up. I did a lot of scapular stabilization, so we did your punches, the number drawing. We worked on some eccentric control. Not all of his rotator cuffs were torn, but his supraspinatus was, so being the primary abductor to get your arm up. So we were able to, he probably came in for about 6 weeks, and we worked twice a week. He did his stuff at home, and he was able to raise his arm up. He was able to get back into bowling and golfing. So it's pretty cool what scapular stabilization and strengthening of the whatever intact rotator cuff muscles you have can actually help increase your function of your arm. I have a lot of people come in with shoulder impingements. They always talk about, I get pain at end range when I lift my arm up. And these people go to the gym. But the issue is they go to the gym and all they do is anterior stuff. They'll do shoulder press, they'll do bench press, deltoid work. They don't do anything for their upper back. There's no rowing, no scapular retraction of any kind, and there's no rotator cuff work. So what I try to do is educate those people on the importance of the other muscles to create that balance between front and back and big and small, and their shoulder impingement will decrease. They don't have that end range pain, and everything kind of works together. People or athletes who come in after surgery, so again, protecting a decompression, so if they just have that impingement and they're going to go in and just clean out any bone spurs or anything else that they got in there, so not necessarily a repair, you want to, again, make sure everything is working efficiently so that you prevent that from happening again or increasing into a rotator cuff tear. Some athletes that you have labral repairs, so after they come back, making sure that that proximal stability in their shoulders is efficient for them to get back to whatever activity they're doing. And then I have patients who have shoulder replacements that do the same thing. Athletes may have hip bursitis or patellofemoral pain center, plantar fasciitis. That's all worked, and I always target hip abductor strength and extensor strength first. And then someone touched on low back pain. I forget who. I think Ant talked about it. Some athletes will come and they have low back pain. So you got to look at, are their hip flexors tight, are their hamstrings tight, where are their weaknesses at, and just kind of hone in on their imbalances and what they're weak at, and I guarantee you that low back pain will dissipate over time. So anyone have any questions, comments? Yeah.
I noticed that a lot of this was geared towards like potential rehab situations, although I feel like your presentation was more about like prehab, avoiding having to rehab it.
Yeah.
But from a strength and conditioning perspective, where can you implement prehab of like specific, like the shoulder is such a small joint, and people look at it from such a broad perspective, and you're doing all these big workouts to make it stronger, but when do you implement working the little stuff to make sure that it's safe before working out the big stuff?
So my recommendation would be I would incorporate it into your warm-up activities, and you guys can kind of add what you think being in the weight room, but I would add it into your warm-up, so actually making sure you're facilitating those muscles. So if you're going to do a squat, doing your hip activation, doing your TKEs where you're getting your quad activation, to warm everything up prior to getting into that big lift. Then you can incorporate some of your resistance if you want to do, full can or extra rotation resistance stuff, maybe into your accessory lift. So do you guys have any added drills to that?
Yeah, we use that same kind of approach. We use a lot of that for activation stuff at the beginning of the workout for warm-ups. So activate all those different areas that tend to be inactive. But you just got to be careful. They're already weak, so you don't want to completely drain them, and then all of a sudden you have no stabilizers when you get to the actual lift where you're supposed to have those stabilizers working. So it's kind of the fine line between activating it and not burning it out, and then later on in the lift, like she was saying, using it in your accessories, or even we've used it as a layover at the very end of the workout. We're waiting for everybody to finish, or even as a finisher, to use it as a finisher to kind of.
That'd be a good thing too. Even on recovery days, if they're on a helo week or a recovery day, you're not, and like I said, if these areas are weak, you're not doing heavy weight. So you can do, I would think you can do that on a recovery day. But you also want to assess your athletes too. So they should be strong in these areas before you're putting loads on them and doing your limb day or power movement. Does that kind of make sense?
I have a question. For low back pain, do you ever use pelvic traction?
I do, but for a patient, that's not really functional.
Okay.
If I have a patient come in, sometimes it works more for herniated disc in younger population. So I'll use that at times, but they can't take that home with them.
Yeah.
Sometimes it works, sometimes it makes it worse. For the majority of people, I probably wouldn't do it. So it all is on a case-by-case basis.
Why would it be worse?
If it's a herniated disc and it's a bigger herniation, it can actually make more of the disc material go out into the spinal cord and make their symptoms worse. So there's a fine line. There's not a whole lot of research. Some of it talks about a suctioning thing that happens where if you distract the spine a little bit, it actually will suction the disc material back in. But again, like I said, there's not a whole lot of research that really says that happens. So I had a patient who had a herniated disc, and the doctor wanted pelvic traction. We did it, and it was actually worse. Prior to that, I was doing McKenzie method exercises, more of your back extension, which is trying to push that disc material back into the center, and he was actually getting better. His walking improved, his symptoms were reduced. Then I threw in pelvic traction because the doctor wanted it, and he was worse. So I probably won't do that again, but unfortunately it was a learning experience. So it really depends on what is causing the back pain.